Today, Dr. Tony Das, who is the Chief of Cardiovascular Services and of Innovative Research at the Walnut Hill Medical Center, will take us to the next level. What's the emerging technologies for treating PAD?
Thank you, Manos. First of all, I want to congratulate Subhash and Manos for an excellent meeting, and thank you very much for inviting me. I am Tony Das. I'll also be known as the guy that's between you guys and lunch right now. So I'll try to, that's how you'll remember this talk. In the next 10 minutes, I'll try to get your attention regarding new devices. We've had some excellent discussion this morning about devices that are already approved. I'm going to talk to you some things that are significantly behind those, but new technology. These are my disclosures. I'm a consultant for a variety of these topics. So we talked a little bit about drug-eluting balloons and drug-eluting stents, but I'm going to give you some insight into what the next steps in these technologies may be. In addition to drug elution, there's also devices that are now coming out that are not drug eluted, that have some specialty options for both balloons and stents. There are new plaque excision devices. Dr. Shamas talked about laser and pathway and Silverhawk atherectomy, but there are others as well. And then there's other new technology that you may not have heard of at all. So the one new drug-eluting stent that's in clinical trials now, we're about to enroll in this trial. This was the initial information that came from the Majestic trial that was done OUS. This is just 57 patients. This is on the Innova platform by Boston Scientific, and the drug is still paclitaxel. The length of the lesions was typical for these type of trials, maybe actually a little bit on the long side, almost 8 centimeters. And the 12-month patency was higher than what we've seen in previous drug-eluting stent trials. Preliminary because there's only 57 patients, and a randomized trial is actually about to occur now compared to the drug-eluting stent, the Zilver PTX that's out there. So we're excited to be involved in this next generation of stents. What about non-stent options? So Intact Vascular actually has a very interesting device. It is not a drug-coated stent in this era of everything being drug-coated. This is a series of tacks. So one of the things that happens in balloon angioplasty in the femoral arteries is that you have dissection. Dissections can be either managed by stenting the entire section or stenting portions of it. So this tack device is a delivery system that has several tacks within one catheter, and you can deliver them at the most critical areas of dissection. You say, well, does this work? Well, here's the trial that was done, the TOPAS trial, and the lesions that were treated were almost 9 centimeters, so typical for the complex vascular stuff that most of us see. And in those, many of them were total occlusions, about a third, and the dissection rate was quite high. As you might imagine, calcified long lesions, you're going to see some dissections. So does this seem to work? 138 patients were looked at and presented at the Link meeting last year, 12-month patency of 76.4%, which is quite acceptable with a TLR rate of almost 90%. We've seen several trials of drug elution which actually mirror this, and so it's interesting to use technology that may not be drug-related and may have some similar benefits. What else is new? Drug-eluting balloons are now coming out with different technologies that might be interesting to us. The chocolate balloon, which we may have described in this meeting previously, is a balloon that has a nitinol cage on it. Can you imagine having a nitinol cage which reduces the dissection potential, but then adding to that some drug? So paclitaxel eluting balloon with the concept of being able to deliver this balloon and to reduce the dissection rate. Here's an example of the ENDURE study. This is a pre and post picture. This is a cartoon of what a nitinol cage around a balloon looks like on the chocolate balloon, and then add to that some drug. And what kind of results do you get? One, you get very few flow-limiting dissections. This is a 6-month ENDURE data. You can also see that there's a significant low rate of bailout stenting. Well, does this really then lead to improvement down the road? At 6 months, it looks as if all patients treated, there was 88.9% patency, and the patients who were treated per protocol were almost 90%. What we look at in drug-eluting balloon trials typically is not restenosis, but late lumen loss. That's what LLL is. And late lumen loss is measured by intravascular ultrasound. And what you can see with the chocolate touch balloon at 6 months is the late lumen loss was at 0.16. Compare that to some of the ones that we've talked about earlier, which are 0.45 and 0.54. It leads to an interesting story. Maybe that there's some benefit to a reduction in dissection followed by drug. certainly a pre-treatment strategy. One of the things that was learned in both of the drug-eluting balloon trials is that a pre-treatment strategy was an important part of the benefit or the lack of benefit of the drug. So are there other things out there that might lead to a pre-treatment strategy? Yes, this is the first presentation of a balloon that's by Cagent Technologies. This is a specialty balloon that's on the horizon called the Serenator. I don't know who comes up with these names, but the idea is basically a device that has serrated metal edges, and the idea is that the angioplasty result then is done in a very uniform fashion. With that, kind of think about it like if you have a checkbook and you rip the check off and you have that serrated edge that you can tear it and it's very uniform. Well, at least sometimes it is, right? The interesting thing here is that there is a potential that with this artery to open and expand in a very uniform way, that there is, fast forward a little bit, that maybe the delivery of drug could be more uniform as well. So as a pre-treatment strategy, there is a possibility that this may be on the horizon as a pre-treatment for drug-eluting balloons. And then you can consider this as a pathway for those by expanding those artery diameters. Once again, still not FDA approved and in clinical trials yet. We talked about several atherectomy devices. We did not hear about the Phoenix device, which is a new atherectomy device. Again, a device which has the potential for doing a couple of things, both cutting and capturing while it's rotating. So it rotates at 10 to 12,000 RPMs, and as it moves through the artery, and the frequency of which then allows the ability for the catheter to then uptake the tissue material. This was studied in the EASE trial, which looked at over 100 patients, and as you might imagine, complicated patients with the potential for distal embolization, but with the ability to capture, there was a decrease in distal embolization compared to what we've heard earlier today, which was almost 10 to 15%, and now this is down to 1%. Low perforation and low clinically driven TLR. There's some devices you may not have heard of. This is the nittyloop. Although when I asked Subhash, I said, have you heard of this? He said, yeah, 3 years ago. That's it. So this is from a Israeli company. Interesting technology that has a Nitinol cage that centers the total occlusion device. So Dr. Banerjee did talk about several devices that are out for chronic total occlusions. This is one which is still being studied and will get FDA clearance and has a coronary and a peripheral indication in the tibial vessels, another way of getting through totally occluded vessels. Another device you may not have heard about is the vascular device. This is a new technology that, if you can imagine, when you open up an artery, there are always areas of it which don't really give to the balloon. They are still resistant. So the calcified areas, they may be more fibrotic. And when you have that, you have to keep on increasing the pressure of the balloon in order to release the lesion. If you can imagine a balloon that's of high pressure inside the nominal pressure balloon, and you can move that balloon to the locations where there actually is that resistant lesion and then blow it up there, you might get some benefit, a balloon inside a balloon. Well, it's been studied and it's under process for FDA clearance, and in addition to that, it's been now looked at with these dimples on the inside of the balloon, that when the balloon resistant portion, the high pressure balloon, is dilated, that these little wells of potential drug elution then can be delivered. So the concept basically is you balloon dilate to pre-treat, and then you take the high pressure balloon, and that takes these dimples and it opens them up, and then the drug is delivered. So another interesting concept, once again, if you look at what happens in drug-eluting balloons now on the left side of the screen, and that is the two balloons that are out there that through basically the inflation and the passage through the catheter, you lose drug. So if you are able to protect the drug, like for instance in the chocolate balloon, the drug is protected by the nitinol cage, or with this balloon, the drug is protected because they're in reservoirs that are underneath, and then they basically come uninvaginated out into the artery, that you might have a reduction. Well, it's been looked at in animal models, and as you can see, those are the balloons that are out on the market, and this is the difference between that and the vascular balloon. The higher bars there are the two drugs and the two balloons that are out now, and then you see these low bars of the cell vascular and the potential for loss of drug. So interesting concepts, once again, still quite early stage technology, but I think it's important that you be aware of what's out there and what's going to be out there in the years to come. So in conclusion, drug elution continues to evolve, not only drug-eluting stent designs, but also drug-eluting balloons and the designs for pre-treatment delivery of these. Chronic occlusions will always be a challenge for us, and it will always keep increasing those challenges and meeting them with new devices. And we had some great talks today on tibial disease, and there's a lot of new things coming out for tibial access. Thank you very much, and have a good lunch.